Welcome and thank you for joining us today as we continue our important mission to change the conversation about primary care and start to dig into why primary care is the foundation for rebuilding our national health care system that's failing to meet the needs and expectations of patients in the country. My name is Gary Jacobs. I will be the moderator for today's live stream. I currently serve as Executive Director of the Village MD Center for Public Policy. Village MD, through its subsidiary Village Medical, is a leading national provider of value-based primary care services. Through Village Medical, we deliver care to patients in clinics, via telehealth, and at home. We believe in delivering primary care everywhere, and the primary care physician is the most equipped to coordinate the care delivery. Village MD also partners with physicians to provide the tools, technology, and operations, staffing support, and industry relationships to deliver high-quality clinical care and better patient outcomes, reducing the total cost of care. Village MD and Village Medical have grown to 15 markets and are responsible for more than 1.6 million patients. Village MD is also the largest participant sponsor of the new CMS DCE model, serving more than 56,000 patients. We are here today to discuss primary care innovations in the Medicare program. Before I introduce our speaker for today, I'd like to provide a brief overview about who Primary Care for America is. And you can see the listing of our founding members. Primary Care for America is a diverse coalition of key partners focused on educating policymakers and health policy influencers about the value of comprehensive, continuous, and coordinated primary care. Primary Care for America's formation serves as a commitment to our continued effort to help improve the health well-being of everyone in America. We know the challenge ahead of us and are dedicated to bring a voice for the millions of individuals, families, and communities that we serve. We would like to take a moment to thank our founding partners for answering the call and joining us on the journey. We know it's not the easiest thing to form coalitions like this, but I think we're all of like mind to focus on primary care and bring it and teach and educate, communicate, and advocate. We're proud to be a founding member of the Primary Care for America Coalition. And without further ado, I'd now like to introduce our guest speaker. Today we have Edith Stowe, Director of Manatt Health Strategies. Edith Coakley Stowe is a director with Manatt Health, an interdisciplinary policy and business advisory practice of Manatt. Edith guides health systems in designing, developing, and implementing innovative delivery models to improve the management and provision of healthcare services. She focuses on providing project management leadership, clinical process design, quantitative analysis, and health reform strategic consulting. She brings almost a decade of experience working with U.S. federal and local governments and a firsthand understanding of the Affordable Care Act impact on both the market and states. Prior to Manatt, Edith served as a health insurance specialist at the Centers for Medicare and Medicaid Innovation, CMMI, within the Centers for Medicare and Medicaid Services, CMS. She led the team implementing the Comprehensive Primary Care Initiative, a payment and care delivery model involving 500 primary care practices in 7 U.S. regions, as well as over 30 healthcare payers acting in partnership with CMS. Before CMS, Edith was a special assistant at the Office of the State Superintendent of Education for the District of Columbia, that's DC here, In that role, she was part of a small team that achieved overdue reforms in the DC educational system for children with disabilities. She started her career as a barrister, gives you a clue to the upcoming accent, at Outer Temple Chamber in London, UK, and later served as an associate for the Judge David Bazelon Center for Mental Health Law in Washington, D.C. Thank you for joining us today, Edith. I'm now going to turn over the presentation to you.
Thank you so much, Gary. Hello, everyone. I'm so grateful to Primary Care for America for this opportunity to speak for a few minutes about innovation to support primary care in the Medicare program. Just a few words about me, which just pick up on what Gary said, sort of the angle that I come at this all from, because I can't pretend to cover the entire swathe of Medicare here. But what I can definitely talk about is the work that the CMS Innovation Center is doing, which, as many of you know, is an animal of the Affordable Care Act and was designed as a way to allow CMS, the agency, to put out and test new models for Medicare to pay for services and to test on a fairly large scale what happens, with a view to scaling those approaches in the Medicare program at large. And I come at this from having been a staffer in that organization from more or less from the beginning, so 2011 to 2015. And during that time, I got to work on the design of something called the Comprehensive Primary Care Initiative, which I'll talk about in a minute, which has morphed into CPC Plus and more recently something called Primary Care First. They're flavors of the same ice cream. And it was a great privilege to work in that role and to work with a team of experts in those years after the Affordable Care Act to think about Medicare fee-for-services, traditional Medicare's role in revitalizing primary care and coming up with a strategy for that, and then building it and launching it in these markets. So all the way from dreaming to implementation. And as Gary said, in the past few years, I haven't been with CMS, I've been with Manatt Health, and we're a consultancy, and we do a much broader range of projects with different healthcare clients around the country, including providers, payers, and particularly with state governments. So actually, in the last couple of years, I've been focusing very heavily in state policy rather than Medicare, but in some important ways, these things come together, which I'll mention in the next few minutes. So what I'd like to do with the few minutes that I have is to say a little bit about how we thought about primary care innovation inside CMS, inside Medicare, when we built our CPC model and what that looked like. And then connect that with what's been going on in COVID, the COVID experience of the last 2 years, and what that means for where we are now, sort of 10 years later and one pandemic later, and offer a few reflections on what might come next for the traditional Medicare side of the house to improve how primary care is supported. And then after that, Gary's going to talk a little bit about Medicare Advantage. Before I get into it, I'll state clearly that the views are my own and not necessarily that of my firm, Manatt, and certainly not those of CMS. I'm 6 years out, and like many of you, I watch closely what's going on there. I have opinions. I'm going to give my opinions, but these are not the views of the agency. Okay, so let's get into this a little bit. What we have here is it's really sort of the big picture as I see it, or as I certainly saw it inside the agency, about what the Medicare program, leaving my MA to one side for just a moment, is doing to support strong primary care. And this has sort of been true for the last 10 years or so. The base case, of course, is paying fee for service, pay for visits. And there's sort of been two big ideas post ACA for how to fix that, how to improve on the base case. On the left is models like the one I worked on. So starting with comprehensive primary care, moving into CPC Plus, primary care first. And those are payments that are specifically for primary care practices with a direct relationship with Medicare and the practice. On the right is the ACO idea, the Accountable Care Organization idea, which is heavily to do with primary care as well, but it's much more about creating incentive for a larger system. What I'm going to do in the next slide, if we can go to the next one, is just unpack each of these big ideas and do a little compare and contrast. And I'll say it once and I'll say it again. It's not a one or the other, because somewhere along the line there was a decision, rightly or wrongly, to allow overlaps between the two. So they're probably both here to stay, and they're both important. And actually there are practices that are in different ways participating in both. So it's not as clean as one or the other, but they do have different consequences. And I think it's worth thinking through how these two concepts play out. So I'd like to actually start with the ACO idea. So that's the idea on the right. And I think most of you follow this well enough to know there is a program called the Medicare Shared Savings Program. There are several other flavors of ACOs, and the concept of ACOs is baked right into the Affordable Care Act. The theory of action here is that in an ACO, providers form an organization, so a network, that works together to manage the health of a relatively large population. So think a hospital system in a town or a large multi-specialty group. Let's go through the bits of how this theory of action works. So for an ACO, on the payment side, what Medicare does is set annual benchmarks for spending and quality for that large population. And the idea is that the group as a whole of providers that serves that population basically comes up with its own strategies to meet those targets for cost and quality for the whole population. If they meet the targets in specified ways, they can earn more money in the form of shared savings at the end of the year. And then the idea is that those savings can flow back to reward the providers. And there are different flavors. So there are some which are upside only, and there are some which include some risk. But always this is about the total cost of care for this large population. And what's interesting, let's put our primary care hat on here, is to look at what happens to primary care practices when they join ACOs. It turns out to be a little bit harder to get a picture of this than you might think. In prep for today, I took a little look. And what the research says is that the signal from the ACO to look at total cost and quality is not as strong as you might think to change what individual practices and providers do and what they take home and pay. So it turns out that, yes, providers have a slightly higher percent compensation for quality than in other practices in general, but they still are being paid pretty much the same, which is a high balance of productivity, how much volume of work is being done. Let's keep going through and then we'll do some more commentary on this. So what's the care model for ACOs? Oh, next, you go back, please. It's still on this slide. We'll remain on this slide for another couple of minutes. The care model here for ACOs is fairly flexible. The idea here is that the ACO is going to manage the health of this population. Primary care is central to that, right? They're going to track the health of the population using risk stratification tools, and they might have, for example, groups for diabetics, medication management across the population, all of those sorts of things. But CMS, Medicare, is not telling them how to do it. Scale and spread. So scale and spread of ACOs is very large now. And the real issue for Medicare now is how fast to move people into the downside risk. And there was actually a little bit of a drop off in uptake of ACOs last year when the last administration got more aggressive. But so the picture you should have about ACOs is that there's a very large footprint at this point. They will stick around, but they're not prescriptive about what actually happens at the practice level. So let's turn to the other side of the house, because that's the side of the house I worked on and I want to have a few things to say about it. Very different theory of action. Here on the Comprehensive Primary Care Initiative / CPC Plus and Primary Care First, the theory of action is all about offering, really testing a form of direct payment and what that looks like to primary care practices, not just a set of incentives for a large group. So let's step through what that looks like. So on the payment side, it's rather specific in a different way of paying practices from fee-for-service, which boils down to dialing down how much practices are paid fee-for-service and dialing up a new payment that represents everything that the practice needs to do to take care of all of its Medicare patients, right? And that's sometimes called the population-based fee or the care management payment or primary care capitation. There's a bunch of different flavors. Primary care capitation is a good way to describe it. And this payment gets paid in advance based on an algorithm about who is attached to the practice. That's called attribution, and it's very fundamental to how these things are built. There's risk adjustment, which means that the payment reflects how high risk the population that the practice is looking after is, and very important. So the idea is to pay more in advance if this is a high risk population. And then really importantly, there's adjustments for quality and total cost of care. And also the idea of leakage, which is how often a patient's going to other providers other than your primary care practice, right? So the idea is we want patients to be sticky and come to this primary care practice. So it's a predictable upfront payment, but it does have a toggle button, if you will, for how the practice does in the last quarter or the last year on quality, total cost of care, and how good they are at keeping their practices sticking to them for care. And this, the topic of today is innovation. So this is the big payment innovation here, is how do we value what primary care does to roll it into that predictable population-based payment. And it's actually quite hard to do this from an administrative and operational standpoint. And as I'll say in a minute, I think personally that that's what CMS should be just continuing to push down on in the next era. So you might be asking on this side of the house, on the left-hand side of the slide, does this mean the primary care practice gets paid less or they get paid more than they would in fee-for-service? And the answer is actually clear. It means they get paid more. So in these tests, it is deliberate that practices actually look at, they get a raise relative to what they would get for fee-for-service to represent the investment in primary care that this takes, the additional work, the staffing, the infrastructure, and so on. So it's at least 10% more. And in our model, early model, it was sometimes up to 30% more. One more point about payment here is this idea of multi-payer alignment. And this was new in the CPC model when we worked on it. This is a brand new idea for CMS to use Medicare in a different way, not just payer, but essentially a leader of other payers in a way that is still compliant with antitrust law, right? So Medicare can't say to commercial payers, you should be paying $5. Absolutely not. And it shouldn't. That's inappropriate. But what CMS can do is go into a region and say, we're going to invest in primary care in this region if we can form some sort of a coalition with the state government, with MCOs and the Medicaid program, with commercial payers, with employers that operate in this region. And we're going to have an agreement, an MOU, that says that we all think that primary care is greater than the sum of its parts. We're all going to pay these population-based fees. We're not going to talk about the price of it, but we're all going to pay it. And we're going to share data with practices in the same kind of way, and we're going to share a quality measure approach. And that, at the time, 10 years ago, was a brand new approach in this model. And it's very encouraging to see that that's now become sort of core business in CMS and kind of core policy, that Medicare should play that kind of a role in these payment models. Finally, and most importantly of all, the care model. So what do these models on the left say about what primary care practices are actually supposed to do? What are we paying for? And the answer is that it's pretty specific, at least in the test that we worked on. We had this idea of primary care core functions, so access and continuity, care management, comprehensiveness, patient and caregiver experience, and planned care and population health. And on top of that, some key expectations about the use of HIT and the use of data to guide improvement, the use of data to track the panel. There's a lot of work. This is real work for practices, and practices were expected to hire new staff to help them with care management. And in our model and its sort of successors, practices have to show things. They have to show Medicare what they're doing. So they had to report in the model when I worked on it 4 times a year. I think they've lightened it up since then, right? Because there's an issue here about scale and spread and how much of this reporting can really be done when you start talking thousands of practices. But they had to show Medicare that they were doing the risk stratification. They had a way of communicating with local hospitals when patients were discharged from the ER. They had to show that they had a family council and were engaging their patients. And, there was accountability there. If practices weren't meeting these milestones, their payment could be diminished or be cut off entirely, go back to fee-for-service, right? This was a demonstration. So there's real innovation here. what we saw was that the Medicare was pretty specific about what we wanted to see, but there was space, you know, back to innovation, for practices to do their own thing here. And what we found was that when practices had a predictable income stream that wasn't tied to visits, there's more space for them to do things like think about how they are tracking risk at the practice level. That's up to them. Think about how they're using telehealth, right? That wasn't such a thing 10 years ago. But the beauty of these models is that there's more space for practices to innovate and think about that. Okay, so 2 theories of action, 2 work streams. Hold that thought. And now let's fast forward to COVID on the next slide. So in 2020, we were hit by COVID-19, of course. And for those of us who think about primary care, it was pretty grim, I think. You know, these headlines, we've all seen them. The one that gets quoted the most maybe was that Larry Green Center one in the early summer of last year. I think it's 35% of practices said they had to furlough staff. And pretty much any study that you look at, virtually every primary care practice in the country will say there was some sort of negative revenue impact from COVID, even though they had emergency telehealth coverage. So there was some sort of extraordinary aha moment, I think, that happened last year. For those of us who work on this stuff, no surprises whatsoever. But for those who don't every day, it's a bit of a shock. Is this sector really so fragile that when in-person visits drop off, practices literally are in danger of closing? And as a society, what are we going to do about it? So next slide. What are we doing about it? Well, there's those of us who sort of think about this and who are in government, who work with healthcare payers, practices in the policy space. I think we're seeing 2 main strands. One strand is about resiliency. And what we've got up on the slide here, it's interesting for those of you who'd like to take a look. The HCP LAN is a sort of public-private partnership that CMS sponsors between Medicare and other payers and leading practices to think about payment reform. And they put out a nice set of tools and calls to action and best practices that you can find on their website. So what we've got here is a really good example of the advocacy and thinking that I think was bubbling up by the end of last year about what does this crisis mean for primary care. So first thing to take away is this idea of resiliency. We just saw last year, and we're still seeing louder calls for all payers to move faster on primary care reform, including Medicare, but not absolutely not just Medicare, all payers, to just go harder and faster. Let's get this fee-for-service set of incentives in the rearview mirror, right? It's been more than a decade of work and we're not going fast enough. The second thought from the LAN work and from many other papers that I'm sure most of you have seen is equity. So to be perfectly frank, the design of the models that I just told you about was not focused on equity. And in some very real ways, the design of these models can have unintended consequences that we have to guard better against. So in particular is the idea of risk adjustment that I mentioned about a payment is higher for each person if they're deemed to be more risky. Well, how do you know how they're more risky, right? So we'll come back to that in just a minute. Next slide. So then this year, as you may know if you're on this call, there's a major report from the National Academies of Science, Engineering and Medicine. And this is important too for those of us in this field, because for the first time we have a major body, I think, looking at the whole sector. And it's underlined, that's my underlining, that these hybrid payment models, right, where we've got population-based payment, like in CPC, like I laid out a few minutes ago, that should be the default with exceptions. So back to the resiliency. Having a way to pay for primary care that is much more certain and population-based is what we need to do. And that idea, I think, has just moved significantly since COVID more into the mainstream than it was before. Okay, so next slide. So where should Medicare go from here? And again, I want to say these are my thoughts. This is not coming out of of CMS, what should traditional Medicare do next? It's got these tests, these legacy tests that have been going on for 10 years. They've moved the market. Medicare Advantage is different. Gary will touch on that. They say don't touch every practice by any means. And now we have a pandemic and a crisis response. I think the other thing is we have a lot of technology that we didn't have 10 years ago around telehealth and virtual care. That I feel strongly has to be factored into all of this. So here's a few recommendations that I would offer. The first one is what we were just talking about with equity. Testing new risk adjustment methodologies to make sure that payment models support health equity. There is a lot of work for Medicare to do here, because risk adjustment in the current models fundamentally uses how much healthcare people got as a proxy for how much healthcare that they need. And fundamentally, that does not provide equity, because people who are underserved have worse health outcomes and they often have lower utilization. So that is a problem that crosses not just primary care, but lots of other payment models and approaches as well. And I think if you're reading the headlines as I am, this issue about improving how equity is supported by payment models is absolutely top of the list of what people are thinking about within the agency, which is great to see. We can expect a lot of work there, but I think it's top of my list too, since you asked. Okay. Item 2, aggressively scale up the hybrid model. So this is probably the biggest ticket item of all. As I said, we've got some models, but they don't have an enormous footprint at the moment. Operationally, this is daunting. Medicare is still set up fundamentally to pay fee for service. And I think as policy people, we tend to forget about operations, but operations are incredibly important. That's how the checks actually go out to docs. And population-based payments are hard to do on the front end because they require so much adjusting. They require totally new data systems and new forms of back and forth between Medicare and providers. But we have learned a lot about how to do that in 10 years of these models, and it can be done. So if you leave this 20 minutes with nothing more, I think item 1 and item 2, scaling up the hybrids and testing risk adjustment methodologies are the 2 things I'd leave you with. There's a few more things to say. So thinking more deeply about the value of telehealth and virtual care. Again, this is relatively new that practices would be doing more than just a little bit of telehealth here and there. Practices are really thinking now about how to integrate this into their week in, week out workflow. And the payment model for that has not been sorted out, right? We're still in the public health emergency, but the payment model for that in my submission needs to be threaded into how we're paying these population-based fees in general. So not just telehealth visits, but actually things that are nothing to do with visits, like remote monitoring somebody's blood pressure. That's population health too. It's absolutely what we should be paying for. Number 4, thinking about the next pandemic. Nobody wants to think about the next pandemic, but I think the experts and the scientists are telling us that it is more likely than not that this will happen again in some way. We could just be looking at more waves of this one. So how are we going to shore up our practices next time? Incredibly important. What is the emergency response going to be so that there's some sort of stable payment? Number 5, more tightly braiding Medicare and Medicaid together. This comes from my work with states, and my experience with states is a lot of help to help improve how primary care is supported. Obviously, some of this is to do with tight budgets, tight public budgets, but CMS has some power here as the regulator of Medicaid to make it easier for states to get their waiver arrangements and things like that, approvals, to come in and do these hybrid models too, alongside Medicare. And as you know, when you put Medicare and Medicaid populations together, that's a very large sector of the population. Finally, leading with predictable cash flow and not risk. So I said this a few minutes ago when we were looking at the theories of action. This is a sort of philosophical point. At different times in the decade of CMS Innovation Center, there have been different philosophies about what we're trying to accomplish with these models and how we operationalize them. And at different times, there's more aggression or less aggression about the idea of providers assuming risk. In other words, the possibility that their pay will go down or be taken away at the end of the year because of their outcomes. Again, my opinion, but for primary care, the more important principle here is that predictability and shoring up the ability to do the work rather than the downside risk. And that's inherent in this design of the hybrid model that we've been talking about. So those are my thoughts that I'd like to offer. And as I said, I have kept things in the traditional Medicare swim lane. So the world of fee-for-service Medicare that needs to be reformed. But because Medicare Advantage has grown so much, we'd be remiss not to talk about Medicare Advantage in this session and what it's doing. And for that, I'm going to turn back to Gary for a few remarks.
Sorry, I was muted. I'm back. Thank you, Edith. Let's start with how exactly Medicare Advantage works and why it's different from traditional Medicare. Traditionally, it's through a private plan rather than through the federal government directly. Unlike traditional Medicare, for any individual pays a separate monthly premium for hospital visits, doctor outpatient prescription drugs. Medicare Advantage typically covers all in one monthly premium, often at low cost to the enrollee, which is really kind of significant. Specifically, individuals with certain chronic conditions enrolled in Medicare Advantage experience better health outcomes at similar or lower cost compared to those enrolled in traditional Medicare. And Medicare Advantage is paid on a capitated basis and really allows freedom for plans to come up with innovative alternative payment models with their downstream providers, whether it be capitation, whether it be shared savings. There's lots of different strategies they can employ in that method. Next slide, please. So we went to the Better Medicare Alliance to kind of get like what's the state of the industry at this point. And when you kind of look at their last report that was recently produced, the report found that Medicare Advantage enrollment is up to 42% of all Medicare beneficiaries, and enrollment is expected to increase to more than 50% by 2030. It's quite remarkable. When I entered Medicare Advantage, we were looking at 5 to 10% of the Medicare population, and to see the uptake is quite remarkable. Medicare Advantage has 43% lower rate of avoidable hospitalizations for any reason as compared to traditional fee-for-service Medicare, and higher rates of screening for conditions such as cancer and depression. Medicare Advantage beneficiaries report a 98% satisfaction rate with their coverage, and Medicare Advantage serves a higher proportion of minority beneficiaries, those with social risk factors, than traditional fee-for-service medicine and Medicare. And I think it's pretty amazing to watch that Medicare Advantage has really become the Medicare area of choice for many low-income and populations that are dealing with health inequities and disparities. And the responsibility of primary care is to be in those communities and to create solutions that are holistically oriented for distressed communities, so that everybody in this country has access to high-end, high-quality primary care. And I'll kind of leave Medicare Advantage at that. And Edith, if you can come back, we're going to go to some questions that we got from the audience, and I'll begin over here with Edith and I, by the way, both live in Alexandria, Virginia, but we're not together at the moment. We're in a screen here, but let's move to some questions here. So, what's the best way to measure value in primary care from your experience?
Okay, this is actually complicated, but I'll give my take, and I'd love yours too, Gary. So I'm going to start with what is not the right way to measure value, and then I'll give some answers about what is better. What is not the right way to measure value is a strict cost accounting by payer population for any given year. And unfortunately, that's how payers set up to work. So this is sort of the central dilemma, right? Payers in this country, even public ones, but certainly private ones, have budgets and a way of looking at value that is essentially tied to cost savings on a relatively short cycle. And that just doesn't work for primary care, right? Because if primary care is a public good, then it's greater than the sum of its parts. So what do we do about this? I think that some of the things that CMS has been trying to do in its models are along the right lines. And that is, of course, measuring the quality outcomes and, of course, measuring the total cost of care, but perhaps thinking about a longer time frame for the total cost of care. Also looking at access. So how good is the practice at providing access to services, and looking at, not just for the people who typically go there, but for the neighborhood, looking at disparities for sure. And looking at this comprehensiveness leakage idea that I mentioned that is a little subtle, but really important. How sticky is this practice for the people who go to it, or is it just another practice that people drop in and out of? Highest value primary care has a following, and it's sticky to the people who go there. Do you have a take on this one, Gary?
Edith, I look at longitudinal primary care as what we aspire to provide to our patients. And if you do longitudinal primary care, you need to have the tools to do it most effectively, right? You need to have analytic capabilities. You need to have a functioning care management infrastructure. I would argue you need to get paid in a capitated model with attributed patients, because it's predictable cash flow to pay for all the cost of the things I just described. And that the measurements to quality have to be agreed upon, whether it be an esoteric formula or whether it be tied to HEDIS or National Quality Forum, but some clear definitions of outcomes that are produced by longitudinal based primary care, I think, is critical to determining value.
I agree.
Yep. But let's keep going then, because I know we could chat for a while, but our next question, should we be anchoring entirely on long-term clinical outcomes, or find a way to reward activities that create value along a patient's chronic disease management journey? Good question. I like that question.
It's a great question. It's a great question because it actually puts the finger on the sort of ACO versus primary care intervention debate that I set up a few minutes ago, right? Because the ACO philosophy is very much get rid of all the process, hold providers accountable for outcomes. The other end of the spectrum is we're going to look at exactly how you did your risk stratification approach. We're going to monitor you on all these different individual activities. And people who criticize that say rightly, you can't scale that. You can't look at every practice's ability to do all these things every quarter. And you're right, you can't do that. So my answer to this, I'm going to say on the fence, is that you need both. I think of course, there has to be accountability for outcomes. But there is this sort of idea, I think, with the hybrid models that it is for something. It is for something specific. It is for a set of specific services that are high value, that include managing the panel, things through chronic care, having care managers for high risk folks, perhaps even saying something about how many staff you need to do And the trick is how to make that specific enough that it is an accountability, but not so specific that that it doesn't meet all these different practices, at a large scale. So, this I think is the central design issue for those of us who sort of work on these models, is to think about what that balance point is. But to answer the question, which is a great question directly, I think it has to be both and. What do you think, Gary?
I'm thinking that you have to kind of look at this in almost a re-engineered format, that, first of all, expecting patients only to come to facilities, probably not the greatest idea for a Medicare population that has multiple chronic conditions. So for us, telehealth has been a tremendous tool to work with our doctors directly and work with our patients, and the engagement has been amazing and really quite incredible. And the fact that we have an at-home program and we're actually bringing home-based primary care to the patients in their homes, especially of late, behavioral health-related issues and social determinants of care issues are impeding people's ability to actually come to offices, let alone add a pandemic on top of that. And I think you have a problem. So we look holistically at primary care as a solution. And when you think about the core challenges, I think it's, we got to solve for all of those kind of issues along the way. But let's move to our fourth question, and our third question, we'll call it, how can we align financial incentives across stakeholders to ultimately benefit patients? That's a good question too.
Another great question. And it gets right to the sort of same collective action problem that I've been talking about, right? When you've got individual payers and purchasers that have bottom line requirements, perhaps even from HR departments of employers, this is a tough thing to say, hey, let's invest. I sort of have two answers to this one. One is Medicare-ish and one is not. So on the Medicare side, I do think that the Medicare program and what it does is so important. And just the experience in working in the models is that Medicare can move the market along by creating a structure of what it's doing and being predictable about how it's paying. It is true that other payers follow, even though that's not the law of the land, they do, and particularly for primary care. So I think that's one part of it. The other part of it, which is not so much in the four corners of this webinar, is that I think state action is really, really important. So in our work, we see a lot of states now, there's a movement of states stepping up to think about total primary care spend across all payers. That's not straightforward at all. There's a mire of definitional issues and getting consensus around that, but state governments definitely have a really important role to play in how they use their insurance commissioners and Medicaid program, and also their employees sort of as a coalition to think about minimum spend across all payers in that state. What do you think, Gary?
Well, I think what you're saying is essentially that the states are in fact the laboratories, and we can really kind of do some creative, innovative work there. And you're doing that. That's terrific, Edith. I think also on the Medicare side of things, CMMI, that grew out of the Affordable Care Act, which we were both involved with a great deal, is playing I believe, a incredibly important function in allowing innovation in Medicare. And I do remember chats with Senate Finance Committee back in the day when Affordable Care Act was going back and forth, that the Innovation Center would highlight bright, shining objects and develop new models that we would test and play with. I think that, I've been an advocate of many of these models for a long time. MSSP as the next iteration of where ACOs went kind of worked really well for our organization. Direct contracting kind of fit our needs really well by being primary care based, having the concept of attribution and capitation, and then shared savings. And I think those are the components that really move the needle overall in managing a Medicare population over a period of time. But that's kind of the way I see it and where we're going. I have more questions, Edith, but I also have some stuff to finish. So I think we have to move on, if that's okay with you. And we'll have lunch in Alexandria at some point, and we'll talk more on it. Okay?
Thank you for having me.
It's our pleasure. Thank you for joining us. It'll be great. So we're going to go back to some slides that address primary care for America and what we're accomplishing through our coalition. This is and has been, there has been a preponderance of evidence that is decades old about the benefit that primary care has on individuals' health outcomes. Despite spending twice as much on a per person basis, people in the US have worse health outcomes from most conditions than their peers in many developed nations, including Australia, Canada, France, New Zealand, and the UK. Really a big problem, right? The COVID-19 pandemic has exposed the flaws and limitations of our current healthcare system and its impact on their patients, expanding gaps in patient access and health quality. It is past time that patients receive the healthcare system they deserve, one that prioritizes their health above all else. And if we move to the next slide. Our mandate is very clear as we see it: deliver a healthcare system that prioritizes Americans' health. As shared by our colleagues, it is time we prioritize and elevate primary care clinicians and the critical role they play in delivering comprehensive patient-centered healthcare. The May 2021 study from the National Academies of Science, Engineering, and Medicine, NASEM, which Edith talked about before, concluded that primary care is the only discipline of medicine where a greater supply is equated to improved population health, longer lives, and greater equity. Operating on the front lines of healthcare, primary care clinicians are uniquely positioned to serve as the keystone of a modernized, high-functioning healthcare system that can enhance patient care and reduce healthcare costs. Primary care physicians and care teams are often the first line of defense in managing chronic diseases, identifying and diagnosing mental health illness, and reinforcing public health activities. Yet their critical role has historically been under-prioritized and under-resourced. Building on the NASEM report recommendations, Primary Care for America has outlined the following guiding principles to transform primary care in America. Next slide. And really like to talk about these principles for a moment. Foundationally, our goal is to position primary care as the foundation of America's healthcare future, with the goal of educating policymakers, their constituents, and influencers on the collective value and understanding of primary care to ensure legislative and regulatory action. We are committed to achieving the following: improve patient outcomes, reduced healthcare costs, increased innovation, and workforce transformation. Next slide, please. So as I described before, it's kind of really important as we set these priorities that we're educating, advocating, and communicating about our purpose and goal. And as you can see, we're addressing the four cornerstones of our overall policy that we outlined before. If we go to the next slide, I'd like to show you that Primary Care for America recently did a call to action by sending this letter to Secretary Becerra outlining our focus areas and 2 key objectives we believe CMS should work urgently to address. These areas are innovation in primary care delivery and payment and primary care workforce transformation and expansion. We look forward to working with the administration over the coming months and years to help shape our healthcare system into one that puts primary care at the center of patient care and prioritizes health first and foremost. You can view this full letter at primarycareforamerica, all one word, .org/press, and take a look at what we're trying to communicate to the Secretary. And I want to conclude by letting you know that tomorrow we'll continue this conversation on Twitter. Primary Care for America will host a Twitter chat at 12:30 Eastern Time. Follow at hashtag PC4America, PC4America. So capital P, capital C, numeral 4 America, to hear more from our partners. And our individual partners will be reacting and expressing their points of view on this. And next slide. Over the next 2 months, we have 2 more events coming up over the next couple of weeks, and we want to share them with you as well. One is Primary Care Innovations in Medicaid on September 9th, and September 23rd, we'll be doing Primary Care Innovations in commercial insurance and in the employer markets. It's very critical from our point of view that we get the messaging around primary care to the various stakeholder groups and constituencies in alignment, so that we're all talking from the same songbook, if you will, and that it's clear that as we evolve and as the coalition evolves and Primary Care for America evolves, that people all across this country, whether they're in rural areas, they're in distressed communities throughout the country, are all being serviced with high quality primary care as the cornerstone of their health delivery model and their health delivery system in the country today. We think that's our message, and that's we're sticking to and talking about to all groups that are going to listen to us and hear what we have to say. Having said that, I thank you very much for listening today. It's been a privilege to be able to share our views with you. Edith and I appreciate your attendance and your questions, and continue again tomorrow on the Twitter feed at 12:30, Primary Care for America. Thank you.